Vitamin B12. Vitamin B12 is another water soluble vitamin which is available as a dietary supplement and a prescription medication. It contains mineral cobalt compound with vitamin B12 activity are collectively known as cobalamine. The ring structure, which is resembling with porphyrin ring, is termed as coron ring, and this coron ring having a 5,6 dimethyl benzimidazole part, and it is also containing a ribose phosphate part. So, cyanocobalamin molecule is comprising of coron ring, a benzimidazole part, as well as a ribosome part. In the body, vitamin B12 take in any form is converted to coenzyme of B12. The coenzyme, two in number, which are called cobamide. These coenzymes do not contain CN and hydroxyl group mentioned in their chemical structure, but they contain one of the following two group attached with the cobalt. One is deoxyadenosyl cobalt, and the second one is methyl cobalamine containing methyl group. The first group, which is containing 5-deoxyadenosine group, is added in the mitochondria forming the active ingredient deoxyadenosyl cobalamine. It is a cofactor for the mitochondrial enzyme methyl malonyl CoA mutase that catalyzes the isomerization of methyl malonyl CoA to succinyl CoA. This reaction is very important in carbohydrate and lipid metabolism. The second component, which is acting as a coenzyme, is the methyl group, methyl cobalamine containing methyl group. The methyl group is added into cytosol to cobalt atom forming methyl cobalamine. It is the coenzyme for methionine synthase, which is essential for the normal folic acid metabolism. 5-methyl tetrahydrofolic acid, which was discussed in B9, donates its methyl group to form methyl cobalamine, which in turn donates methyl group to homocysteine, forming methionine. Methionine is later converted to its derivatives that act as a donor of methyl group needed for transmethylation reaction, including formation of phosphatidylcholine, one of the compound lipid. The folic acid vitamin B12 interaction is vital for the synthesis of purine, thymine, and DNA, and has been already discussed in the section of folic acid. RBC's formation suffer from vitamin B12 deficiency because of their higher turnover rate. The absorption of vitamin B12 is complex as compared to other. There are certain salivary glycoprotein in hepatocorrin. They are required to combine with the dietary cobalamine. The intrinsic factor is secreted by the parietal cell of the gastric mucosa and is present in the highest concentration in the fundus of the stomach. And for the intrinsic factor complex, excessive amount of HCl is required, which help in absorption of vitamin B12. In the circulation, vitamin B12 taken up by the plasma protein, which is known as transcobalamine 2. From this combination, B12 is taken up by the body cell, especially liver and bone marrow. Vitamin B12 is now transferred from its combination with transcobalamine to transcobalamine 1 which carries most of plasma B12 and bind it tightly. The transport of B12 by transcobalamin has advantage over transport by 2, whereas B12 bind to transcobalamin 2 is rapidly cleared from blood. The clearance of B12 bound to transcobalamin 1 require many days. The circulating cobalamin bind to the receptor on the cell throughout the body and is internalized. Most of around 90% is stored in the liver. So transcobalamin 2 will rapidly clear it from the blood while transcobalamin 1 help to store. Clinical conditions which are associated with vitamin B12 deficiency is the pernicious anemia. It is the disease which primarily arises due to the absence of intrinsic factor in the gastric juice. And the main reason of deficiency of intrinsic factor is the autoimmune phenomena in which antibodies are generated against the intrinsic factor, so that it cannot allow vitamin B12 to transport into the circulation. Pernicious anemia shows severe anemia, which is one of the megaloblastic anemia with mild jaundice, anorexia, flatulence, diarrhea. It is also evident that inefficient erythropoiesis is seen in the severe deficiency. The anemia of vitamin B12 deficiency is rarely due to the tissue folic acid deficiency. Vitamin B12 in the form of methylcobalamin, if you recall, folic acid, which is responsible to convert homocysteine into methionine, and during this reaction 5-methyl tetrahydrofolic acid, which is the reduced pool, will give their methyl group to the cyanocobalamin to synthesize methylcobalamin, which is now acting as a coenzyme for the conversion of homocysteine to methionine. The THF, which is released in this reaction, will enter into the other active body pool of tetrahydrofolic acid to serve as a carrier of one carbon to the different reactions which play vital role in supply of purine and pyrimidine and DNA to the cells which are undergoing into high mitotic cell division. In the absence of all these reactions in which 5-methyl tetrahydrofolic acid is converted into THF and will release its methyl group and transfer it to the cobalamin. So there is decreased availability of TH, which will decrease the capacity of body to store folic acid that can only be stored as polyglutamate form, and resulting is the non-maturation of nucleic acid, and cytoplasmic maturation will remain same because RNA and protein supply to these cells continues. Hematological abnormalities of B12 deficiency can be reversed by an increase intake of folic acid. B12 deficiency can also cause irreversible damage to the nervous system, reflecting paresthesia, ataxia, loss of position and vibratory sense, and optic neuropathy. The neurological symptoms are believed to result from a decreased supply of methionine, which normally provide one carbon, that is methyl group, for the synthesis of choline. Choline is required for the synthesis of phospholipid lecithin, and important component of cell membrane and myelin sheath. So, B12 deficiency, by giving rise to a decreased supply of lecithin to the myelin sheath, result in an impaired activity of nervous system. Another important thing which is related with the deficiency or arising of the megaloblastic anemia, which arise due to folic acid deficiency and B12 deficiency, the duration is different. Due to B12 deficiency, the anemia that arises is a slow progressing because of the sufficient availability of the store of vitamin B12. While the megaloblastic anemia, which arises due to folic acid deficiency, it will arise immediately once the deficiency occurs. So, of conversion of homocysteine to methionine, hyperhomocystinemia results to appear to be the risk factor of arterial thrombus. Problem that can arise due to the defect in B12 deficiency is the accumulation of methyl malonic acid and its precursor, that is propionyl CoA, in the body. This results in the incorporation of abnormal fatty acid containing an odd number of carbon, mostly 15 and 17, into the molecule of lipid forming cell membrane, including the myelin sheath. The abnormalities of nervous system produced by B12 deficiencies are not corrected by excessive folic acid administration. In fact, folic acid, by masking hematological manifestation of B12 deficiency, may not only mask the diagnosis of pernicious anemia but may aggravate the neurological damage. Deficiency of vitamin B12 can also arise and seen when there is operation that lead to a lack of intrinsic factor, that is partial gastrectomy results in this condition because this factor is secreted by the upper part of the stomach that is spared in this operation. Drug decreasing HCl production, for example, proton pump inhibitor and other antacid, can also decrease the absorption of vitamin B12. There are certain laboratory tests that can be conducted to check the deficiency. Along with that, there are certain drugs, for example, colchicine, neomycin, ethanol, and potassium chloride, can interfere in the absorption of vitamin B12. Old age, after the age of 60, vitamin B12 malabsorption may arise. So, the dietary supplements must be required and must be taken to minimize the chance of deficiency. In the laboratory testing for B12 deficiency, we can check the concentration of B12 which is found to be low in deficiency, as well as there are certain tests that can identify pernicious anemia, which is resulting due to B12 deficiency. The urinary excretion of methyl malonic acid and homocysteine is increased in case of B12 deficiency. As I said, that methyl malonic acid is involved in the which is converted into succinyl CoA with the help of vitamin B12 in terms of 5-deoxyadenosine, which is one of the coenzyme form of vitamin B12. For the treatment of pernicious anemia, vitamin B12 is considered as a treatment of choice. It controls abnormalities of hematopoiesis as well as nervous lesions which arise due to B12 deficiency. Now we can understand that vitamin B12 and folic acid both can cause megaloblastic anemia, but in case of folic acid deficiency there is no nervous system involvement. And the second important thing in folic acid deficiency is that the manifestation of megaloblastic anemia is rapid as compared to pernicious anemia, as compared to vitamin B12 deficiency, because vitamin B12 store can fulfill several month requirement of vitamin B12 in the body once they are stored, while folic acid cannot store for the longer period of time. Usually 100 microgram of vitamin B12 by injection once a month is sufficient to control the manifestation of pernicious anemia. This dose is effective only by injection because the vitamin enters the body directly when introduced by this route. However, it has been seen that when vitamin B12 is given by mouth, the large doses, that is 300 microgram per day, are required. Even they cannot absorb in the absence of intrinsic factor, they can absorb. The last is daily recommended allowance. Daily recommended allowance of vitamin B12 in a male adult is 1.8 microgram per day to 2.4 microgram per day, while this requirement will remain same for the female adult. In case of pregnancy, a minute increase in the amount is required to cover the requirement of fetus. Thank you so much.